Having discussed about the basics of hematopoiesis before, now the next thing what we are going to discuss is on the actual hematopoiesis, the hematopoietic basics. That's what we're going to discuss. The moment you discuss about the hematopoiesis, the most important thing, the next thing what we are going to discuss is on the stem cells. The moment you call hematopoiesis, the next thing what we have to know is about the stem cell, which is located right here, the hematopoietic stem cell. So this is what we typically call as something called a pluripotent hematopoietic stem cell. This is what we refer to as something called a pluripotent hematopoietic stem cell. So what are the nature and characteristics of a pluripotent hematopoietic stem cell? There is another entity called a multipotent hematopoietic stem cell or a committed stem cell. So which means it still can give rise to different lineages of cells. So many students will have confusion between a pluripotent hematopoietic stem cell versus a multipotent or a committed hematopoietic stem cell. For example, if you ask me this common myeloid progenitor and a common lymphoid progenitor, this tends to be the committed hematopoietic stem cell or a committed stem cell or a multipotent hematopoietic stem cell. That is different. You can call this as a multipotent or you can call it as a oligopotent stem cell. Why? Because this can give rise to many lineages of cells. For example, you can see mast, basophil, your eosinophil, granulocyte, monocyte, all these things are originating from the, and even including megakaryocyte and erythroid lineage, all these things are originating from the myeloid progenitor only. But it cannot give rise to lymphoid lineage, which means it needs a separate committed stem cell, which means this is only multipotent or an oligopotent. It is not pluripotent. It cannot give rise to all the cells in the bone marrow. But the moment if you tell it's a pluripotent hematopoietic stem cell, it can give rise to any lineage in the bone marrow, lymphoid, myeloid, erythroid, then plasma cell, whatever you want it can give rise to, depending on the growth factor activity and depending on the differentiation of a particular cell. But apart from that, the pluripotent hematopoietic stem cell means everything. It can differentiate to any and everything in the bone marrow. So that's what about pluripotent hematopoietic stem cell. So if you ask me about the characteristics, so this is a very important thing. If you ask me about the characteristics of the pluripotent hematopoietic stem cell, what are going to be the characteristics? The first characteristic of pluripotent hematopoietic stem cell, it is non-committed. It is typically non-committed at the same time, which means it doesn't express any lineage specific markers. No expression of or no lineage specific markers. For example, if you ask me the most important myeloid lineage marker, for example, CD11C, I can tell CD11C or CD13, 33, all these things are myeloid lineage markers. These specific lineage markers will not be expressed by stem cells, pluripotent hematopoietic stem cells. That's one of the very, very important points. This is the most important point. Does not express any lineage specific markers. Number 2, it expresses certain stem cell markers. These are not that important. So what are the examples of stem cell markers? So if you ask me what are the examples of stem cell markers, the first example of a stem cell marker is CD34. CD34. So why this CD34 is very important? CD34. Why the CD34 is very important? Because this CD34 is the one that is going to adhere these stem cells to the bone marrow stroma. That is the bone marrow stromal cells. It is the one that is going to adhere the stem cells to this stromal cells or the bone marrow stroma. So that is why this is very important marker. This is the one that attaches the stem cells. So that is a CD34. Second thing, you have something called a CD117. CD117, or simply you can call, many other names are there for CD117, which is also called as c-KIT or also called as something called as stem cell factor. So there are other names for this. These are the other names for CD17. CD17 you would have encountered in GIST-like tumors also, gastrointestinal tumor, but still here also it's very important, CD17. So what is the function of CD17 if they ask you? It is the one that increases the stem cell survival and proliferation. That increases the stem cell survival and proliferation. So c-KIT, CD117 and or otherwise called as stem cell factor is again very important stem cell marker. And next thing you have something called CD133. Stem cells have a lot of membrane protrusions. If you see in the electron microscope, these membrane protrusions are actually maintained by this CD133 only. These are again an important stem cell base marker. So this is a stem cell marker again. Number 4, if you ask me, CD110 is there. Otherwise simply you can call it as a thrombopoietin receptor. Other names for this is a thrombopoietin receptor, or you can even call it as a CMPL. CMPL. All these things are again stem cell marker, CD110. So if you ask me what is the function of the CD110, it is the one that promotes the stem cell growth. Apart from CD117 is the one that promotes the stem cell survival and proliferation, CD110 is the one that promotes the stem cell growth. So very important. So the most important of all these things, if they ask you, answer is CD34. Even though there are CD34 positive stem cells and CD34 negative stem cells, but technically speaking, the CD34 is the most important stem cell marker, which is a pluripotent stem cell marker. Very, very important point. So these are the characteristic markers that are present in the stem cell. And the moment you talk about the stem cell, the next thing what you have to know is about the stem cell homing or hematopoietic stem cell homing, which means there are certain things that like hold the stem cells within the bone marrow without making the stem cells leak out of the bone marrow. There are certain things which can hold the stem cells within the bone marrow. So what are things that home the stem cells within the marrow? Very important. There are two factors that are very important. One is the CXCR4, this is the chemokine receptor, and the second one you have something called a factor, that's a chemokine like factor, that is called SDF1, that's called stromal derived factor number 1. So these are the two things that are very important. Stromal derived factor is synthesized by the bone marrow stroma and stromal cells, and CXCR4 is present on the stem cells. This is CXCR CXCR chemokine receptor. This is the one that is very, very important, that attaches the stem cells within the bone marrow stromal cells, so preventing the stem cells from leaking out of the bone marrow. This is what we call as HSC homing, otherwise called as hematopoietic stem cell homing. So this principle we can use. For example, we can use in certain therapeutic situations where you have something called stem cell harvesting. Stem cell harvesting, we have a whole set of video and discussion of this stem cell transplant. But if you ask me about stem cell harvesting, there are two ways of stem cell harvesting. One way is to directly get from the bone marrow, and second one you can even culture, and the third one you can even take it from the peripheral blood. Peripheral blood also you can do stem cell harvesting. If you want the stem cells in the peripheral blood, it's very difficult, isn't it? The stem cells are homed within the bone marrow, and you can't have any stem cell in the peripheral blood in a normal adult patient. So how will you take the stem cells from the peripheral blood? By detaching the stem cells from the bone marrow stroma and from the bone marrow. How will you detach? You have a drug that blocks the CXCR4, that is called plerixafor. So you can write as plerixafor. So plerixafor is the very important molecule, which is a CXCR4 inhibitor or CXCR4 antagonist. So this is the one that is going to release the stem cells from the bone marrow. They are going to detach the stem cell attachment to the bone marrow stroma, and the stem cells are going to enter the peripheral blood, where you can harvest and you can culture the stem cells, and you can multiply the stem cells into different numbers, and you can reinfuse the stem cells into different person called allogenic or the same person called autologous transplantation. So these are the basics. It's a very, very, very important molecule, plerixafor, which we currently use. Along with plerixafor, generally we use GCSF also, which also is one of the compounds that mobilize the stem cells apart from the plerixafor, which is again very important. But plerixafor is a very important question for your exam. So this is what we call as HSC homing. So with this, we can commit ourselves to the RBC basics. So erythroid basis. So basics. What are the things that are important for erythrocyte? The first thing that is important in the erythrocyte lineage is the stem cell itself, because that is the one that is going to any cell for that matters. And the second thing that is very important is the common myeloid progenitor. This common myeloid progenitor has another name. Also, we are going to call this as a colony forming unit, GEMM, because it's going to give rise to granulocyte, erythroid, monocyte, megakaryocyte lineage. All these things they are going to give rise to. That is why typically we call the common myeloid progenitor as CFU-GEMM. Then the CFU-GEMM forms the next unit called, it's not mentioned here, that's called a blast forming unit erythroid. This is the next thing that this common myeloid progenitor is going to form. And next thing what you are going to get is number 4, that is the colony forming unit erythroid. And from the colony forming unit erythroid, you are going to get different lineages. The successors of the erythroid lineage, that is the proerythroblast, normoblast, and finally you get the reticulocyte and you get the mature erythrocyte finally. So these are the next generation of erythroid cells. So you are going to get from the colony forming unit erythroid. You have a lot of growth factors are very important for commitment into the erythroid lineage. But once it commits into the erythroid lineage, that is once this blast forming unit and colony forming unit is formed, once this blast forming unit and colony forming unit is formed, the most important growth factor that is important for differentiation into further differentiation into erythroid lineage and survival of this erythroid lineage cells is the erythropoietin. If you ask me where the erythropoietin is extremely important, erythropoietin is most important for this CFU cells. Most important, because this CFU, this colony forming unit erythroid cells will not survive without erythropoietin. Very, very important. Others, maybe erythroblast, reticulocyte, to an extent can even survive without other growth factors. I mean, they can take up other growth factors and may even survive without erythropoietin a little bit, but CFUE will not survive and they will go for apoptosis without erythropoietin. The most important place where the erythropoietin acts is on the CFUE, that is a colony forming unit erythroid cells. It's important for the blast forming also, I'm not telling, but CFE is one that is highly susceptible for erythropoietin action and very important for that. Apart from that, to commit into the erythroid lineage, you need a lot of things apart from the erythropoietin. You will be needing a GM-CSF, you might be needing a SCF and the IL-3 also, because SCF and IL-3 is important not only for erythroid lineage cells, it's also important for many other lineages like monocyte, macrophage, and other myeloid lineage cells, megakaryocyte, all these things it's important. Again, GM-CSF is also extremely important for commitment, not only for one particular lineage. GM-CSF is very important for many different lineage cells, which means this SCF, stem cell factor, interleukin 3 and granulocyte macrophage colony stimulating factor, GM-CSF has something called overlapping functions, which means they're not important for one particular lineage, it's important for many lineages. To specially tell if of the erythroid, it's erythropoietin that is very, very important. If you ask me 4 important growth factors that are important for commitment towards the erythroid lineage, first is the stem cell factor, second one is the interleukin 3, third one is the granulocyte macrophage colony stimulating factor, and fourth one is the erythropoietin, out of which the first 3, IL-3, SCF and GM-CSF have overlapping functions, not only important for erythroid, it's overlapping into many other different lineages as well. So all these things are very important to understand. So now let us assume the RBCs have committed and they have formed about the blast forming unit and a colony forming unit. So after committing into the erythroid lineage, you have multiple sublineages. It's going to transform into different cells. So you have to know about the complete erythropoiesis. So the next thing what you are going to see about how the erythropoiesis kicks off from the blast forming unit. Erythropoiesis kicks off from the blast forming unit. So how the erythropoiesis is going to kick off from the blast forming unit is we can see in a different picture. So I have not given one thing in this picture. For example, initially you have something called a blast forming unit. So this blast forming unit is going to come from something called common myeloid progenitor, otherwise referred to as CFU-GMM. Then this colony forming unit is going to form something called a CFU erythroid. So otherwise called as colony forming unit erythroid from BFUE. This BFUE is going to give rise to something called the first of the proper erythroid lineage cell, that is called a proerythroblast. That's called a proerythroblast, which is also referred to as something called a pronormoblast. That is also another name is there, pronormoblast or a proerythroblast. So you think any importance of the proerythroblast and pronormoblast is there? But before going into this one, you can even tell one more important point, because if you understand this, it's very easy to understand other things as well. So there are 3 things I'm going to tell. Whenever you have any hematopoiesis, for that matters, there are some changes which are mandatory and that is going to definitely happen in the when they go into successive generations. What are the changes? The first one is the cell size. Cell size is going to progressively decrease, which means as you move into subsequent successors of the precursors and the successors will have progressively decreasing sizes, which is very important. The only exception, if you ask me, for this phenomenon is in the granulocyte series. That too in only one area in the granulocyte series, where you get something called a myeloblast, which is a precursor. This myeloblast is a precursor which becomes a promyelocyte. This myeloblast is relatively smaller in size and this compared to the promyelocyte, which is larger in size. This is actually violating the common principle that we told here, because the cell size generally tends to decrease in the successor compared to the precursor. But here the successor is having a relatively large size compared to the precursor. That's why this is the only exception in the entire rules what we are going to discuss. Number 2, you are going to see about the nuclear size. changes in the nucleus. What are the things that are going to have a change in the, things that are going to change in the nucleus? The first one that's going to change the nucleus is the nuclear size itself. The size is going to decrease. Very important. As the size becomes smaller and smaller, the nucleus size becomes smaller and smaller, the nucleus is going to become more compact. Why they are going to become more compact? Because the chromatin is going to condense. Which means initially in the precursors, the chromatin will be more open in configuration, lazy in configuration. After that, it is going to become more compact and more compressed, and it's going to become more condensed in nature. Number 3, you are going to have something called a nucleoli that is going to disappear. The nucleoli is going to disappear, definitely. So, over time the nucleoli will disappear. So these are some of the changes that are going to happen. Because the chromatin condenses, as the lineages progress, the nucleus tends to become dark blue. At the end of the lineages, nucleus generally tends to become dark blue. Even in some lineages, the nuclei completely disappear, like erythrocyte lineage, where the nucleus will be extruded out, which you are going to see. So, but generally the nucleus becomes darker blue as the lineages, as the things progress in that particular lineage. Third one, you are going to have a cytoplasm. So cytoplasm size will increase because the nuclear size decreases. So the cytoplasm will relatively appear increasing in nature. Whereas in RBC, the cytoplasm is the only thing that is found in the mature RBC because there is no nucleus. So that also can happen, but the cytoplasm tends to increase in amount. So that is also one of the important changes. And the cytoplasm tends to become less basophilic, which means cytoplasm will become less basophilic, which means initially it tends to be more basophilic. As they progress, the cytoplasm tends to be less basophilic in any lineage. These are the common changes. I told you the exceptions also. Coming to the erythroid lineage. Erythroid lineage is also certain, differences are there, but still erythroid lineage is also nothing different from the common rules that we apply in hematopoiesis. The cell size is going to progressively decrease, number 1, which is very important. The cell size is going to progressively decrease. You can see in the example itself which I have shown. See the cell size of the mature RBC and see the proerythroblast size. You can compare itself and you can see the cell size is going to be very small. And the cytoplasm also becomes what? More cytoplasm compared to nucleus. More cytoplasm. Which means, as I told you the previous rule, the nuclear cytoplasmic ratio will decrease. Which means the cytoplasm will increase and the nuclear cytoplasmic ratio will decrease over time. And initially the nuclear cytoplasmic ratio will be very high, which means the nucleus is relatively larger and the cytoplasm relatively smaller. At the end, if you see, the nucleus will be very small or extruded. In fact, the cytoplasm is the one that is completely there. So nuclear cytoplasmic ratio will decrease as the lineages progress. And you can see the cytoplasm also have become less basophilic. In fact, in the mature RBC, the cytoplasm tends to be salmon in color, salmon or pink in color. That is because of the accumulation of the hemoglobin that stains a little bit pink or salmon. So that is why the cytoplasm tends to be salmon or pink in color in case of a mature RBC. So these are the general changes that happen in the RBC morphology also. But what are the changes that are specific to this proerythroblast? That's what we're going to ask. What are the changes that are specific to this proerythroblast? The most important exam question they are going to ask is the hemoglobin synthesis will start in the proerythroblast stage only. The hemoglobin synthesis will start in the proerythroblast stage, which is one of the very, very important factors. Very, very important things to note. Then the proerythroblast is, apart from that, if you ask me the other things, you can see a very thin rim of cytoplasm, which means the NC ratio is very high. So very, very thin cytoplasm will be seen. And you can see an open chromatin. That means it means a very open, loose chromatin will be there. It will not be compact. It will not be that dark blue. It will be very light blue or even purplish red in color, the nucleus, because of the very open configuration of the chromatin. Apart from the most important point, if you ask me, it's the HB synthesis that starts in the proerythroblast stage. Second thing, if you ask me, this progress to the second phenomenon that is called the early normoblast. This is called the early normoblast, or simply you can even call it as a basophilic normoblast. Basophilic normoblast. What is the importance of the basophilic normoblast? Actually here the chromatin starts condensing, but it's not fully condensed. It will become more and more compact and relatively more darker blue. You can see here it's relatively more darker blue, isn't it? So that's what happens. Apart from that, there is nothing much significant in case of early normoblast. Then you get something called an intermediate normoblast. Intermediate normoblast, which is nothing but something called a polychromatophilic normoblast. Polychromatophilic normoblast. So the most important point is there in this polychromatophilic or intermediate normoblast, that is the hemoglobin is detected first by your routine stains. Hemoglobin can be detected first by your routine stains in this intermediate normoblast only, that is polychromatophilic normoblast. Next it moves on to next thing called a late normoblast. Late normoblast is otherwise referred to as something called a orthochromatic normoblast. Like how I told you polychromatophilic normoblast, similarly you have something called orthochromatic normoblast, that is what the other name for a late normoblast. So what is the importance of the late normoblast? The most important feature of a late or orthochromatic normoblast is the nucleus will become pycnotic, which means the nucleus will become fragmented and the nucleus will be destroyed. Nucleus will become pycnotic in nature. And one more interesting point is at the end of the late normoblast stage, your nucleus will become completely extruded. The nucleus become pycnotic during the late normoblast stage. As the thing progresses and at the end of the late normoblast stage, the nucleus will become completely extruded from the cell, which means the cell will be without nucleus in the subsequent generations. So which means in the reticulocyte and the mature RBC, there is no nucleus. You don't have a nucleus in the reticulocyte and the mature RBC. Very, very important point. If there is no nucleus, no replication, which means in all these three things, since the nucleus becomes pycnotic and in the late normoblast stage, and the reticulocyte and mature RBCs generally do not contain nucleus at all in the first place, no mitosis, which means no cell division possible in these three stages: late normoblast, reticulocyte and mature RBC stage. So which means if you ask me, there is one proerythroblast which becomes 4 early normoblast, which means mitosis is possible, then it becomes 8 intermediate normoblast, then it becomes 16, because during intermediate normoblast still mitosis is possible, so it becomes 16 late normoblast. The moment it forms late normoblast, no more mitosis is possible, mitosis stops, which means you are going to produce 16 reticulocyte and you are going to produce 16 mature RBC, because there is no nucleus at all in reticulocyte and mature RBC. So overall, if you ask me, one proerythroblast is going to give rise to 16 RBCs. So this is the number you have to know. If you ask me which is the one that is most mitotic, if somebody asks you which is the one that is most mitotic, that is the proerythroblast. Proerythroblast is the one that is most mitotic in nature, because that is the one that's going to give rise to 4 early normoblast, which means 4 times the number, 4 different cells it's producing, 4 daughter cells it's producing, but apart from that only doubles, isn't it? So the most mitotic is the proerythroblast stage. So these are some of the important things that you have to know. Apart from that, if you ask me about the EPO receptors, which of the things that doesn't have erythropoietin receptors, if they ask you, then the reticulocyte and the mature RBC, these are the 2 things. Once again, they do not contain nucleus, at the same time there is no erythropoietin receptors in a reticulocyte and a mature RBC, because reticulocyte and mature RBC are not susceptible to action of erythropoietin. Clear? So all these things are again very, very important. Now, if you ask me, what are the difference between nucleated RBCs and what are the difference between non-nucleated RBCs? Non-nucleated RBCs, if you ask me. If you ask me about the nucleated RBCs include a proerythroblast, you have and a normoblast stages, all the normoblasts, because they have nucleus. So normoblast, early, intermediate, late normoblast, all these things come under nucleated RBCs. Generally, you don't see in the circulation. They are not seen in peripheral blood. They are not seen in PB. PB means peripheral blood. So they are not seen in the peripheral blood. Whereas non-nucleated RBCs, they are seen in the peripheral blood, and it includes 2 things. One is something called reticulocyte, and second one you have something called a mature RBC. These are the 2 things that are included under non-nucleated RBCs. If you ask me, both nucleated as well as non-nucleated RBCs can be seen in the bone marrow. That's a well-known fact. So bone marrow can contain both mature RBCs and reticulocytes as well as the non-nucleated RBCs like proerythroblast and normoblast. All these things can be seen in a bone marrow. But the most important point is these are not seen in the peripheral blood in normal individual, and these are seen in the peripheral blood. At the same time, one more point if you want to know, these non-nucleated RBCs contain erythropoietin receptors. I mean, nucleated RBCs will contain erythropoietin receptors, but these non-nucleated RBCs will not contain erythropoietin receptor. They do not have erythropoietin receptors in the first place, and they are not susceptible to the action of erythropoietin. These are some of the difference between non-nucleated and nucleated RBCs. I told you generally these non-nucleated RBCs are not seen in the peripheral blood, but sometimes you can see in the peripheral blood whenever there is accelerated erythropoiesis. Whenever the erythropoiesis is accelerated due to many reasons, like for example the thalassemia, where erythropoiesis will be ineffective. Erythropoiesis will be ineffective in thalassemia, but it might be accelerated. So in those conditions you might see a NRBCs, that is nucleated RBCs in the peripheral blood as well. So now let us dissect the reticulocyte versus a mature RBC. So what is the difference between a reticulocyte and a mature RBC? Reticulocyte tends to be relatively larger in size. Obviously it's a precursor cell. Mature RBC tend to be relatively smaller in cell, obviously because it is a successor. As the common rule, this must be smaller in size. And reticulocyte is typically a little bit more basophilic in nature, the peripheral blood, whereas mature RBC tends to be a little bit salmon pink in color. The cytoplasm of the mature RBC tend to be salmon or pink in color, salmon colored or pink colored. So why this is important? Because this is how we differentiate reticulocyte from the mature RBC in the peripheral blood. Because both do not contain nucleus. Both do not contain nucleus. That's a very important hallmark of these cells. That is how we differentiate. Because mature RBCs you can easily see by the routine stains itself, but reticulocytes cannot be seen by routine stains, and you need special stains like supravital stains. For example, the examples of supravital stains are new methylene blue, brilliant crescel. All these things are, some of the examples of brilliant crescel blue. All these things are examples of a supravital stain, which stains the live cells. Then only you call it a supravital stain. So these are the difference between reticulocyte and mature RBC. Why this difference are very important? Because this is how we differentiate the reticulocyte from the mature RBC in the peripheral smear. Why the cytoplasm is more basophilic if somebody asks you reticulocyte? Because it still contains some RNA fragments. Still contains some RNA in the cytoplasm. And mature RBC will not contain any RNA. No RNA. Complete loss of RNA. So since there is no RNA in a mature RBC, you do not have any basophilic discoloration of the cytoplasm. So this is the difference between a reticulocyte and a mature RBC. So we have discussed almost everything about a mature RBC and a reticulocyte. At the same time, how long it will take from a proerythroblast. So to complete from proerythroblast to a mature RBC stage, how long it will take? That's also a question. It's approximately 5 to 7 days. It's going to take around 5 to 7 days. Similarly, to convert from a reticulocyte to a mature RBC, how long it's going to take? It's going to take approximately 1.5 to 2 days. Again, very important numbers. 1.5 to 2 days. Approximately 1.5 to 2 days is the number at the time taken for a reticulocyte to become a mature RBC. The total duration of that takes from proerythroblast to mature RBC is approximately 5 to 7 days. So if you want to illustrate this is in the way of a bone marrow, I can tell in the illustration in the form of a bone marrow also. If you take this the bone, if you ask me, you have a BFUE which becomes a CFUE, which becomes a proerythroblast, which becomes a normoblast stages, and this normoblast becomes a reticulocyte. This reticulocyte is released in the circulation, and this reticulocyte is going to become a mature RBC. And where is going to be erythropoietin influence? The erythropoietin influence is going to be only in this. Erythropoietin does not influence. This mature RBC has no influence from erythropoietin, which means the lifespan of the mature RBC is not affected by the erythropoietin. Very important point. Lifespan of the mature RBC is not affected by erythropoietin. Once mature RBCs are released, they are on their own. Lifespan depends on the peripheral destruction. If there is hemolysis, antibodies or not, extravascular destruction, the membrane integrity of the RBC, so many things determine the lifespan of the mature RBC, not the erythropoietin, even reticulocyte for that matters. And again, if they ask you, maximum effect of erythropoietin is seen on the CFUE. Maximum effect of erythropoietin is seen on the CFUE, that is colony forming unit erythroid. So conversion here from here is 1.5 to 2 days in the peripheral smear. So all these things are Very, very, very important point. So that's what I'm going to tell you. Then after knowing all these facts, we can even discuss on the erythropoietin. So what is going to be the erythropoietin? How we are going to tell what are the nature of the erythropoietin? Because you all know that erythropoietin is a hormone, more of a hormone. And where erythropoietin is synthesized from? In the kidney, 90%. In the peritubular, interstitial, not in the tubules, non-tubular cells, interstitial fibroblast-like cells. Fibroblast-like cells typically near the proximal convoluted tubule. This is a usual location, but apart from these are the interstitial fibroblast-like cells. This is where you are going to get from the this is where you are going to get the erythropoietin from. That is the reason why in interstitial kidney disease, because kidney disease is divided into many different things. For example, you have a tubular kidney disease, interstitial kidney disease, then you have polycystic kidney disease, then you have glomerular kidney disease. These are some of the etiologies of CKD and acute kidney injury. But if you ask me where the erythropoietin deficiency will be maximum, erythropoietin deficiency in kidney disease, erythropoietin deficiency in CKD, as well as anemia in CKD, anemia of chronic kidney disease. Where you ask me maximum, you will see in interstitial kidney disease. Interstitial kidney disease, since you are going to tell, erythropoietin deficiency typically happens in the CKD compared to AKA, you can tell chronic interstitial kidney disease. In a CKD, chronic interstitial kidney disease, you are going to get a maximum erythropoietin deficiency and hence you are going to get a maximum anemia. So all these are very important points. Where the remaining 10% comes from, the remaining 10% may come from the liver. So what is the most important determinant of erythropoietin secretion? What is the most important determinant of erythropoietin secretion? Is the oxygen tension that is seen in the blood and the tissues. Hypoxia, very important stimulator. If there is more oxygen tension, for example, if the oxygen tension in the blood and the tissues are more, erythropoietin secretion will decrease. The oxygen tension decreases, that is what we call hypoxia, then erythropoietin secretion will increase. We can see also the molecular mechanisms of how erythropoietin is increased or decreased. That's also very important. So what are the molecular mechanisms? So whenever you have a high oxygen tension, let us see that. So because there are two things that are very important in the form of an enzyme called PHT, then you have something called von Hippel-Lindau protein is there. All these things, how they interact with erythropoietin. So whenever you have a very high oxygen tension, increased oxygen tension, what is going to happen? You know very well that you are going to have reduced erythropoietin. Whenever you have reduced oxygen tension, you know very well you are going to have increased erythropoietin. You all know that. Though how the reduced oxygen tension increases erythropoietin is by increasing something called hypoxia inducible factors, typically 1 alpha and 1 beta. So this is the mechanism. They increase the hypoxia inducible factors 1 alpha and 1 beta. This in turn will increase the erythropoietin gene transcription and it will increase erythropoietin synthesis. But how there is a control, let us see. For example, whenever the oxygen tension is high, it increases the activity of one more protein called PHD2. It increases the activity of one more protein called PHD2. This is a hydroxylase enzyme. This hydroxylase enzyme does one important thing, that is, I told you there is something called HIF1 alpha and 1 beta, hypoxia inducible factors. This PHD2 is going to hydroxylate this HIF1 alpha and 1 beta. The moment this HIF1 alpha and 1 beta are hydroxylated, this becomes a target for binding with another protein called VHL. That's called von Hippel-Lindau protein, comes from von Hippel-Lindau gene from chromosome number 3. You all know that already. So when the VHL binds with this HIF1 alpha and 1 beta, they tend to break down the HIF1 alpha and 1 beta. So which means this PHD2 hydroxylation facilitates the binding of HIF1 alpha and 1 beta with von Hippel-Lindau protein. Then when VHL binds with this HIF1 alpha and 1 beta, they break down the hypoxia inducible factor, resulting in reduced erythropoietin. Whenever there is low oxygen tension, the reverse happens, which means the activity of PHD2 is going to decrease, which means the hydroxylation of HIF1 alpha and 1 beta will decrease, and because of that, VHL binding with the HAF will not happen, will be very much less. Because of that, you will have a very high erythropoietin release. So this is the reason why you're going to have a high erythropoietin in terms of hypoxia and low oxygen tension. So these are the molecular mechanisms. So that is also one reason why if you have a mutation VHL gene or if you have mutation PHD2 gene, if they are not functioning properly, then you might have a high erythropoietin release resulting in polycythemia. This is also possible. All these things are very, very likely you can get. These are some of the important things that you have to know about erythropoietin. Apart from these things, you also can know that where is the erythropoietin effect maximum. Erythropoietin receptors are maximally seen and the erythropoietin effect of erythropoietin is maximally seen. All these things answer must be CFUE. As I already mentioned, it must be colony forming unit erythroid. At the same time, where you don't have EPO receptors, again as a revision, I already told you it is not seen in the reticulocyte and mature RBC. You don't see this. And what is the type of erythropoietin receptor? Erythropoietin receptor is something that comes under something called NRTK, that is called non-receptor tyrosine kinases, which means they are a Janus kinase. They are Janus kinases. So whenever you activate Janus kinase is whenever activated, this Janus kinase EPO receptor is a type of Janus kinase receptor. So whenever these are activated, you are going to cause STAT protein dimerization. Because the STAT pathway, you are going to have some cellular effects. So which means erythropoietin is a NRTK happening through, it's working through something called the JAK-STAT pathway. So this is a very important point. Not only erythropoietin, we already discussed in endocrinology. I told you already that TINS, TERS, GM-CSF and growth hormone. So TINS means erythropoietin, thrombopoietin, prolactin. TERS means interferon, interleukin. Then you have something called GM-CSF, granulocyte macrophage colony stimulating factor and growth hormone. TINS, TERS, GM-CSF and growth hormone are acting through NRTKs or JAK-STAT pathway. So these are the cellular, this is how erythropoietin mechanism of action is all about. And what cellular effects you are going to get? They are going to increase the transcription of something called GATA1 and FOG1. This GATA1 is extremely important for erythroid lineage pathway. FOG1 is not that specific, but this GATA1 is extremely important for erythroid lineage differentiation. So that is the reason why this erythropoietin can increase the GATA1 transcription and increase the survival and lineage differentiation towards erythroid lineage. So all these things are very important things that you have to know about these things. So now whenever you think about RBC morphology, so what is the normal RBC morphology? RBC morphology, suppose if you are going to see in the peripheral smear or in electron microscope, if you see what could be normal RBC morphology, normal is something to be called as biconcave shape. Everyone knows. So this biconcave is the normal RBC. So it looks something like this. So this is a biconcave shape of RBC. So that's how in this thing it looks like. If in animated versions and all, if you see RBC will be drawn something like this. So these are all some examples of how a biconcave shape is. But what are the abnormal shapes? There are a lot of, you might get a spherocyte, loss of this biconcave shape where the RBC may be typically round in nature, spherocyte. Or you might get a acanthocyte, echinocyte. There are a lot of dysmorphic RBCs, and shape of the RBCs may differ. So that is, that's what we are going to discuss in the next subsequent session. But apart from that, so apart from the normal biconcave shape, what are the other things that you have to know? The lifespan. It's a very important number. Lifespan of the RBC is approximately 90 to 120 days, and the lifespan completely depends on the peripheral circulation of the RBC and what are the factors that determine the thing is in the periphery, not in the bone marrow. Lifespan of the RBC is totally dependent on the destruction and the hemolysis, most importantly, and your erythropoietin does not affect the lifespan of the RBC because RBCs do not contain erythropoietin receptor at all in the first place. So more than that, so you know all these things. So apart from that, how will you compare the RBC size? For example, I am telling you, how will you compare RBC size in peripheral smear? When you take a flow cytometry, you know that RBC size, size ranges from 80 to 100 femtoliters. But how will you tell what is the normal size of the RBC in a peripheral smear? In a peripheral smear, normally RBC size is compared with that of the nucleus of a small lymphocyte. Very important point. So this is the nucleus of a small lymphocyte. and this should be equated with of the size of the RBC. So this is how we tell it's a macrocytic or microcytic based on the smear picture, not based on your your values that are shown by the laboratory instruments, but by smear. How will you find out if they ask you? It is by comparing the size of the RBC with the size of that of the small lymphocyte. At the same time, what is the normal RBC morphology in the peripheral smear is that you have something called a central pallor. That's again a very important thing. Central pallor. There is something called a central pallor that is characteristic of RBCs in the peripheral smear, which means normal central pallor must be less than or equal to approximately less than or equal to 1/3 of the size of the RBC or 1/3 of the diameter of the RBC. This is the normal size of the central pallor. If it is more than this, for example, if you see more than 1/3 central pallor, then you call it as a hypochromic RBC, which means there is less hemoglobin. That's why, because that this red color, pink color of the RBC is due to the hemoglobin. In the center, there will be less hemoglobin, usually aggregation. That is because hemoglobin starts forming in the poroerythroblast stage itself, and the cytoplasm is the one that contains hemoglobin. The nuclear area will not contain hemoglobin, which means once the nucleus is extruded at the late normoblast stage, only the sides will contain the hemoglobin. The nuclear area will be still free and it will not contain that much hemoglobin. That is supposed to be the reason why you have a characteristic central pallor where there is no hemoglobin accumulation in the center, because there was a nucleus in that position before that. That is the reason. So if you don't see central pallor, if they ask you if the RBCs do not show a central pallor, then you can tell this as a hyperchromic RBC. Then you can call it as a hyperchromic RBC. So this is how you differentiate a hyperchromic, then size of the RBC, microcytic or macrocytic. In the peripheral smear, this is how you're going to tell. And apart from, after knowing all these things, then we can go to the dysmorphic RBCs. So you can see something called dysmorphic RBC. This is a slide that is showing a dysmorphic RBC. So what are the dysmorphic RBCs? First one, you can see here what is shown in this slide. If I zoom in and show, you can see something called, what I have rounded is the teardrop RBCs. Teardrop RBC, otherwise we can call it as dacrocytes. Dacrocytes. What are the conditions that produce dacrocytes? First one is anything that produces extramedullary hematopoiesis. The characteristic example of an extramedullary hematopoiesis is a thalassemia. Thalassemia. Or you can see in a myelofibrosis where there will be splenomegaly. At the same time, any condition that produces splenomegaly also can result in, apart from extramedullary hematopoiesis, can produce a dacrocyte or a teardrop RBC. So three classic conditions you have to know is thalassemia, primary myelofibrosis, and you see something called a splenomegaly. So these are the conditions where you are going to see a dacrocyte or a teardrop RBC. What are these? It's very easy. You can see these are the sickle RBCs. These are sickle RBCs typically seen in sickle cell anemia or sickle cell trait. So other name for the sickle RBCs are called as drepanocytes. Drepanocytes, these are the other name for sickle RBCs, drepanocytes. So typically seen in a sickle cell anemia or a sickle cell trait. That's all. And number C, what you are going to see here is something called a fragmented RBC. You can see here, these kind of fragmented RBCs are referred to as something called cystiocytes. Cystiocytes, where you can see these fragment RBCs typically are in the something called MAHA, that's called microangiopathic hemolytic anemia, or you can see in a macroangiopathic hemolytic anemia. So what do you mean by a microangiopathic hemolytic anemia? Microangiopathic hemolytic anemia typically happens whenever there is a clot formation in the microvasculature. Because of the small clot meshwork will be there, the RBC has to move through the microclots in the microvasculature. Because of that, the RBC will be deformed, sometimes it can be teared off. So that's what we call the cystiocyte. So example of a microangiopathic hemolytic anemia is characteristically HUS-TTP complex, or it can happen in a DIC, otherwise called disseminated intravascular coagulation. Macroangiopathic hemolytic anemia typically happens when there is a mechanical structure and the RBC has to pass through that mechanical structure and it is teared due to shear stress while passing across the mechanical structure. Example, when they are passing through a mechanical device like LVAD, which means left ventricular assist device, which you place it in terminal heart failure patients. Then you can get when the RBCs are passing through a hemodialysis circuit. Absolutely possible. Then it can happen when there is a prosthetic valve in situ. prosthetic valve in situ. In these kinds also, the histiocytes are possible. So these are the conditions where you typically see a fragmented or tiered RBC, that's called a histiocyte. Then D, if you ask me, these are nothing but a macrocyte. Sometimes you can call this as a macroovalocyte also, macrocytes, or you can call it as megalocytes. A lot of names are there for this, megalocytes. So what are the conditions where you see macrocytes? Macrocytes, you have a separate topic on a macrocytic anemia. Macrocytes typically show something called a loss of central pallor, which means they will be hyperchromic. Central pallor, which means they will be hyperchromic, and this is how you can see a lot of cells are there which have lost the central pallor. These are all examples of a macrocyte, and they will be more hyperchromic compared to the usual RBCs. Typically, you can have two types of macrocytosis. One is called a megaloblastic macrocytosis, and second one is a non-megaloblastic macrocytosis. Non-megaloblastic macrocytosis, which we have a separate discussion we are going to discuss later on in the subsequent topics. Megaloblastic macrocytosis typically seen in B12 and folate deficiency, and drugs cause that. There are a lot of conditions that produce impaired erythropoiesis, impaired DNA maturation. Non-megaloblastic, there is DNA maturation will not be impaired, and typically seen most common classic example where you see a non-megaloblastic macrocytosis is alcohol intake, chronic alcoholism. Simple. So we'll discuss in detail about that. So next, if you see this one, what you are saying in this is the spherocytes. Spherocytes are formed when you have a biconcave shape of the RBC. When you have a biconcave RBC, when the membrane is teared up, for example, some of the chunk of the membrane alone is removed. For example, let us assume this membrane is removed, this area of the membrane is removed. What will happen? So this part of the membrane is removed. Whenever this part of the membrane is removed, what will happen is the RBCs has to adapt a low surface area, which means this RBC will have a low surface area, but they might have a normal volume, completely normal volume. So which means the surface area by volume, ratio will decrease, and that is what is the genesis and birth of a spherocyte. In a spherocyte, the surface area to volume ratio will be decreased, which means only the surface area will be reduced because of some of the part of the RBC, from the membrane of the RBC will be damaged and will be removed, and remaining will form a very compact and tight RBC. That's why you get a spherocyte. Even in a spherocyte also, you will have a loss of central pallor. Then how will you differentiate a macrocyte from a spherocyte? Very simple. Macrocytes will be bigger, spherocytes will have a normal MCV and a normal size. As simple as that. That is how you differentiate, because in both these conditions you have a loss of central pallor. Typical examples where you see a loss of central pallor, this spherocytes, classically in hereditary spherocytosis, or you can see in other hemolytic anemias. Other hemolytic anemias where the membrane will be damaged and some part of the membrane may be removed, like intravascular as well as both extravascular hemolysis. Intravascular as well as extravascular hemolysis. Best example will be hereditary spherocytosis, already I told you. At the same time, you can have something called autoimmune hemolytic anemia. At the same time, you might also have something called ABO incompatibility. So some examples I'm telling you. So you have a whole separate 2 video discussion on hemolytic anemias as well, but just I'm telling as an example here. At the same time, you might also see in certain other conditions like MAHA also, very rare, but microangiopathic hemolytic anemia, some spherocytes are still possible. But these are the typical conditions where you see hemolysis. Okay, then what are these? These are elliptocytosis. Elliptocytosis, where you can see this elliptical shaped RBCs. Typically, classic example is hereditary elliptocytosis. That is where you see elliptocytes typically. But apart from that, you can also see in some cases of thalassemia, some case of iron deficiency anemia, and some cases of myelofibrosis, just as a part of increased red cell distribution because different shapes of the RBCs will be seen. That's what we call increased red cell distribution with anisopoikilocytosis. That's what we call alteration in the shape of the RBCs. So as a part of anisopoikilocytosis, you might see elliptocytes also in these conditions. But the classic exam related condition is hereditary elliptocytosis. Then what are the things you are seeing here? You are seeing here something called RBCs with cytoplasmic projections. In both these conditions, you are seeing RBC cytoplasmic projections. Both G and H here in this condition, we are going to call it as spiculated RBCs. speculated RBCs in both these conditions. If you ask me about what do you mean by speculated RBC, there are two types of speculated RBCs. The first one, you have something called an acanthocyte. Acanthocytes. Second one, you have something called echinocytes. Echinocytes are otherwise referred to as something called Burr cells. Burr cells. Both acanthocytes and echinocytes many times may coexist, which means the only difference between acanthocyte and echinocyte is what is the nature of the cytoplasmic projection. If it's an irregular cytoplasmic projection, you call acanthocyte. If it's a regular cytoplasmic projection, you are going to call it as a echinocyte or a Burr cell. Simple. So what are the conditions where you can get an acanthocyte? Typically you can see in a myelodysplastic syndrome. Even though I am telling the causes, but acanthocytes and echinocytes may coexist with each other, which is very important thing to understand. MDS. Then you can see after splenectomy. Post splenectomy you can see a acanthocyte, and you can see in many neurodegenerative disorders. Neurodegenerative disorders you can see. Then you can see in hereditary A-beta lipoproteinemia. A-beta lipoproteinemia. So this is a very important condition. Hereditary A-beta lipoproteinemia is a very important condition. It's an exam favorite where you can see acanthocytosis in the peripheral smear. So other name for this A-beta lipoproteinemia is called something called Bazin-Kronwig disease. Bazin-Kronwig syndrome. So this is what the other name for A-beta lipoproteinemia. So all these things you have to understand. Similarly, echinocytes, where you can see the characteristic example where you see echinocytes is in the Zeev syndrome. Again, this is an exam favorite. Where you get this Zeev syndrome, everyone knows that. Zeev syndrome is a typical triad. What is the triad of Zeev syndrome? You have something called hemolytic anemia. Then you have associated cholestatic jaundice. And finally you will have a transient hyperlipidemia. In fact, all these conditions, whatever written will be transient hyperlipidemia. This is the triad of something called the Zeev syndrome. Where you see Zeev syndrome? Typically in a chronic alcoholism. This is where you see in Zeev syndrome. Apart from hemolytic anemia, even though it's not a part of the triad, you will see a lot of Burr cells in the peripheral smear. So one of the important differential diagnosis of seeing Burr cells is Zeev syndrome, very important. Again, it's in chronic alcoholism. Apart from that, you can see in uremia. Uremia also you can see this Burr cell anemia. Then you can see in pyruvate kinase deficiency, again exam favorite. Apart from Zeev syndrome, this is also an exam favorite, pyruvate kinase deficiency congenitally. Then you can see as a part of artifacts. Artifacts, even echinocytes, acanthocytes can be artifacts, but this also can be seen as a part of artifacts in the first place. So these are the conditions where you can see echinocytes or Burr cells. Then as we move on to the next segment you can see something called target cells. Target cells are otherwise referred to as something called codocytes. So what do you mean by target cells? So this is otherwise called as bullseye cells, where there will be something called there will be loss of central pallor, but you can see a clear halo of pallor around that central hyperchromic area. You will have a central hyperchromic area that will be there, which means the central loss of pallor will be there. Apart from that, you will have a clear pale area surrounding, a disc of pale area surrounding the central hyperchromia. This is not seen in spherocyte or macrocyte. So this is a typical target cell where you see what are the conditions that produces this target cell or codocyte. You can typically see in hemoglobinopathies. That is due to clumping of hemoglobin. In hemoglobinopathies, like especially in thalassemia, what happens is the other normal chain. For example, you have an alpha chain and beta chain. If beta chain in a beta thalassemia is not produced, alpha chain will produce in excess, that form clumps. So that can get accumulated in the central portion. So that is the reason why you can get a target cell in a thalassemia. Or you can get in hemoglobin, yes, in many conditions you can get. You can get in liver disease also. You can get in post-splenectomy patient. After splenectomy, you can get a target cell. You can get in something called LCAT deficiency. LCAT is a cholesterol metabolism enzyme. You would have studied lecithin cholesterol alkyl transferase. You would have studied this in that LCAT deficiency. In these conditions also, this is an exam favorite. This LCAT deficiency is also one of the important DDs for target cells. Then this one is nothing but a stomatocyte. So when you call a stomatocyte, stomatocytes have something called a slit-like central pallor. They have something called a slit-like central pallor. That is what we refer to as something called a stomatocyte. Where is his stomatocyte? If they ask you, can see in liver disease, in hepatic disorders. You can then see in hemolytic anemias. You can see in hemolytic anemias. Then you can see in a condition, very, very extremely rare condition called hereditary stomatocytosis. Hereditary stomatocytosis. These are the conditions where you can see this stomatocytes. And K and L are very special. These are called as the bite cells, and next one, these are called as the blister cells. Whenever you see typical, both these things can be seen in one characteristic condition called G6PD deficiency. So this is where you see this bite cells and blister cells. The reason for why you get this bite cells, you can see some books will tell these bite cells are a form of cystiocytes, but it's separate according to textbook. So what is a bite cell is, you can see a lot of areas the RBC appears to be bitten like an apple logo, isn't it? So that is the reason why you call them as bite cells. So what is the reason for the bite cell is because of the denatured hemoglobin. This denatured hemoglobin is what we call as Heinz bodies, and they tend to deposit on the membranes. They damage the membranes, and this part of the damaged membranes due to deposition of the Heinz bodies, that is the denatured hemoglobin, is what we call it. What is the source of this bite, where the macrophages identify this area and they're going to bite that area off. That is what we call, and that area appears in the peripheral smear as a bite cell. So that's what it's a, some books tell you it's a form of cystiocyte, but I won't tell, because books tell it's a separate entity. So these are the different dysmorphic RBCs. So I showed you all these things. For example, I showed you the teardrop cells, I showed you the drepanocytes, sickle cells, I showed you spherocytes, elliptocytes, echinocytes, acanthocytes, then macrocytes. Then we have seen the target cells, we have seen the bite cells, blister cells. So many things we have seen. All these things are very important for your exams about the dysmorphic RBCs. Once you have known about this dysmorphic RBCs, next thing is you have to know about the RBC inclusions in the basics of the RBC. So this slide shows very important thing is about the RBC inclusions. So what are the RBC inclusions? Let us go one by one. So image A, you can see very here, this is nothing but a basophilic stippling. This is what we call it as a basophilic stippling. You have a stippled appearance of the RBC. So this is what we, with a blue color dots are there, this is what we call it as a basophilic stippling. If they ask you what are the conditions, typical example is the lead poisoning where you see basophilic stippling. But apart from that, what are the conditions where you see basophilic stippling? You can tell whether it's a coarse basophilic stippling or if it's a fine basophilic stippling. Where will you see a coarse basophilic stippling? First condition where you see is a lead poisoning. Typically, classic example, coarse basophilic stippling. Second one, what you will see is the sideroblastic anemia, which means lead poisoning itself is a type of sideroblastic anemia only. So in these conditions, you will see a basophilic stippling. Fine stippling you can see in many conditions like thalassemia, which means ineffective erythropoiesis. That's all. Thalassemia. Then you can see in megaloblastic anemia, B12 or folate deficiency. In all these conditions of ineffective erythropoiesis, you might see a fine basophilic stippling also. But what are these stipples made of? If they ask you what are these basophilic stipples made of, these are nothing but the RNA, because mature RBC generally do not contain RNA. When they contain these RNA fragments, it is called like basophilic stippling that appears as blue dots in the cytoplasm. So this is the basophilic stippling. Then if you ask me what are these are nothing but this B and C are together we can discuss. These are nothing but the Pappenheimer bodies. These are nothing but the Pappenheimer bodies. These Pappenheimer bodies are also referred to as something called a Pappenheimer bodies are also called as siderophilic granules. Pappenheimer bodies. What are the content of the Pappenheimer bodies is nothing but the iron. Iron is the content. This is nothing but the unused iron. Where will you get unused iron? Unused iron, classical example where the iron utilization is reduced is in the sideroblastic anemia, where the iron enters the RBCs but it cannot be used still. It happens in sideroblastic anemia where the protoporphyrin synthesis will reduce, because Iron only when it combines with protoporphyrin it becomes heme. So if there is iron but still there is no protoporphyrin, heme cannot be formed. This free iron can be clumped up in the RBC cytoplasm. That is what we call siderophilic granules. Siderophilic granules, or otherwise we call it as Pappenheimer bodies. So this is the iron. It's made of iron. So in a normal routine Romanowski stain, that is the classic example of a Romanowski stain is a GMSR right stain. You all know that. In the classic GMSR right stain, Romanowski stain also you can see this Pappenheimer bodies, but it is best seen to confirm that it is iron. You can stain by Prussian blue. This is a Pearl's Prussian blue stain where the iron will appear as blue colored granules within the RBC. So this is classical example of a siderophilic granule iron accumulation within the RBC is called as Pappenheimer bodies. Very important. So typically seen in a sideroblastic anemia. Very rarely this Pappenheimer bodies can also be seen in hemolytic anemias. At the same time, it can also be seen in certain hemoglobinopathies. Possible. And this is an example of a ringed sideroblast. Remember, out of all the inclusion bodies I have told you, the ringed sideroblast is the only inclusion body that cannot be seen in the peripheral smear because it can be seen in the bone marrow only. You can see this is a Prussian blue stain again. You can imagine this as a Pappenheimer equivalent in the bone marrow. You can imagine like that, but still it's not exact. First you can imagine like a Pappenheimer equivalent of bone marrow where there is iron accumulation. In these cells. You can see a lot of this ring-like iron accumulation is there around this nucleus of the sideroblast. So that's why it's called a ringed sideroblast. It's nothing but best stained with Pearl's Prussian blue, and this is seen in sideroblastic anemia. The next one you can see is this is a Cabot ring. You can see this is a it can be like loop, or even it can be like a figure of 8 appearance, like an 8 color figure of 8 appearance. All these things are possible with the Cabot ring. So what are the conditions where you can get a Cabot ring? The Cabot ring, what it is made of is nothing but it's thought to be, I told you Pappenheimer bodies and ring sideroblasts are due to iron accumulation, whereas basophilic stippling is due to RNA. But this Cabot ring is due to remnant mitotic spindle. These are due to remnants of the mitotic spindle, and again it can happen in any condition that produces ineffective erythropoiesis. For example, in lead poisoning, it can happen in myelodysplastic syndrome. It can even happen in a megaloblastic anemia, which means any condition that produces ineffective erythropoiesis, you might see a Cabot ring. These are some classical examples where you see a Cabot ring. Apart from that, you can see these kind of inclusion bodies. These are called as Howell-Jolly bodies. One important thing, what are these Howell-Jolly bodies if are made of? If they ask you, they're made of DNA remnants. So they are typically made of DNA. This is where your Howell-Jolly bodies are made of. At the same time, this is very easy to confuse with one other inclusion body that is called Heinz body. We can easily confuse with Heinz body, which also looks a little similar to that of the Howell-Jolly bodies. But a very important difference with Heinz body is Heinz body typically attached with the membrane, whereas Howell-Jolly body will not be attached to the membrane. You can see very clearly it is little bit, inside the membrane. It is not attached to the membrane. So Heinz body is made of denatured hemoglobin, whereas Howell-Jolly body is made of your DNA remnants. So these are the differences. But where will you see Howell-Jolly bodies? Howell-Jolly body, typical example if they ask, it's post-splenectomy, because this DNA are removed by spleen generally, DNA containing RBCs. But in the splenectomy, this DNA containing RBCs may be sometimes circulating in the peripheral smear, resulting in the appearance of the Howell-Jolly bodies in the peripheral smear. So possible. Post-splenectomy is the very classical condition, exam, or any condition that produces asplenia. Next thing, you can even get again in a megaloblastic anemia due to ineffective erythropoiesis. At the same time, you can also see this Howell-Jolly body in hemolytic anemias. Possible. In all these conditions, it is possible. I told you already, Heinz bodies are due to denatured hemoglobin, but where will you see Heinz bodies? Typical examples where you see Heinz body is in the G6PD deficiency. Classical example. Or you can in many other unstable hemoglobin conditions. For example, HB cone is there. So a lot of unstable hemoglobins, you can still see a Howell-Jolly body, absolutely possible. Final inclusion body, last one we are going to see is the HbH, hemoglobin H. Ironically, that happened in this H image also. So that is what we refer to as something called a HBH. I mean, this H accident happened by accident, so I'm not responsible for that. That happened by accident, so that's a HBH disease. So where will you see in HBH disease in 3 alpha gene deletions? 3 alpha gene deletion thalassemia typically results in HBS. We have a separate whole lot of discussion on HBH disease in thalassemia section, but right now I'm going to discuss only on what are the inclusion bodies in HBH. These are HBH inclusions. Your dot like structures which is seen here, and typically this is seen in, I mean, these cells are also called as something called golf ball cells, because they have an appearance similar to that of the golf ball. That's why these are also referred to as something called golf ball RBCs or golf ball cells. This is nothing but HBH disease, and this is due to inclusion of HBH. If you ask me why HBH is there, this is a 3 gene deletion of alpha thalassemia, so you have a lot declined alpha chain production, but the beta chain production will be normal. So which means there is relative excess of beta chain compared to the alpha chain. This excess beta chain will precipitate and form tetramers because there is no alpha, because adult hemoglobin should be made of 2 alpha and 2 beta, but here there is no alpha, which means only beta has to precipitate. There is no other option. They precipitate as beta 4 tetramers. So this precipitation of beta 4 tetramers is what we refer to as HBH. This is what we call HBH. Gamma 4 is called HB bards. This beta 4 tetramers is what we call HBH, and this precipitated beta 4 tetramers is what is going to give rise to appearance of this dot like structures that is seen in the HBH disease. That is what we call it as golf ball RBCs or golf ball cells. So these are the different inclusion bodies in the RBCs. I think with this we are bringing an end to the hematopoietic and erythropoiesis section, as well as the RBC, dysmorphic RBCs, as well as the RBC inclusion section. In the next section, we will discuss in detail about the RBC physiology, as well as how the hemoglobin is produced and how hemes in this happening and what is the relation clinically with porphyrias, and all these things we'll be discussing in the subsequent sections.